Hello and welcome to our on-demand presentation on reducing commercial tobacco use and promoting lung cancer screening as a part of Enpro's Michigan Cancer Control Initiative. My name is Julie Campbell, and I'm also joined by Elise DeYoung. We are both quality consultants with Enpro and two of the team members working on our Michigan Cancer Control Initiative. Because Metastar is providing continuing education credit for this presentation, we need to inform you, no commercial support has been received for this learning activity. No one in control of content has any conflicts of interest. To earn CME credit or Certificate of Participation, you need to read the introductory CE information, view the webinar, and complete an evaluation. So first of all, just a little bit more information about Enpro for those who may not already be familiar with us. Enpro is a nonprofit organization and a national leader in healthcare quality improvement and medical review. We work with healthcare providers to promote adoption and use of evidence-based best practices and processes to achieve healthcare quality goals. Enpro also represents Michigan in the Superior Health Quality Alliance, under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. Our goal is helping healthcare get better with a commitment to improving quality, safety, and efficiency across the healthcare continuum. In the lung cancer screening component of this initiative, we work with participants to improve tobacco use screening and counseling, as well as support processes for identifying and referring eligible patients to lung cancer screening. Enpro's Michigan Cancer Control Initiative incorporates 5 key strategies. So first is increasing community awareness for early detection. Getting the data that's available out there to patients, communities, and also healthcare providers to understand the current state of lung cancer and also what can be done to improve incidence and mortality. Also, evidence-based interventions, which we'll be talking about later today. So these can be things like client reminders, so the notifications that we're sending to patients when they're out in their day-to-day life and outside of the office visit with clinicians. Just to make sure that we're reminding them if they are at risk, maybe when their next appointment is, when they're due for screening, just so that they're keeping that at the top of their mind. And also provider reminders is an example of what may fall into evidence-based interventions. So we know that when the patient is coming in, the providers have a number of things that they want to address with the patient. So making sure that if lung cancer screening is one of those things that the patient is eligible for, that there are mechanisms within the practice that remind the provider that they want to talk with the patients about that at the visit. Also, personalized technical assistance. So through this initiative, Enpro has the opportunity to work individually with clinics and health systems to either refine the processes that they may have for identifying patients eligible for lung cancer screening, or if there isn't already a program in place, help to plan and implement a process for identifying these patients and getting them referred for lung cancer screening. And then leveraging EHR and data. So quite a bit of what we do in quality improvement is based on the data that's available. So this may look like looking at those quality measures for tobacco cessation counseling. How can we move those and improve those to improve patient outcomes? And also identifying patients who may be eligible for lung cancer screening. So maybe it's just collecting that list of patients who are eligible so that as providers go along, they're able to identify those patients more easily and track them on their path to screening and then results in management. And then also provider and community education. So again, getting the resources, data, and tools that are available out to the communities, to providers, to help support the great work that's already being done. And that's an example of what we're doing today with this learning session as well. The goals of this project component are to improve identification of tobacco use and lung cancer screening eligibility within patient populations. We also hope to increase knowledge and confidence involving lung cancer screening criteria among care teams. And then also, we hope to support providers working in those areas throughout the state where lung cancer incidence and mortality and/or commercial tobacco use prevalence is high. Again, getting these resources into the hands of the providers and the communities that need them the most. For this initiative, we collaborate with the MDHHS Cancer Prevention and Control Section. And we also have a contact at the American Cancer Society that provided tobacco cessation resources that you'll see in this presentation today, and also that are widely available for you and the public as well. MPRO is also a member organization of the Michigan Cancer Consortium, which is a group that brings together public and private organizations to collaborate to reduce the burden of cancer in our state. The MCC develops and maintains the Cancer Plan for Michigan. It has resources for health professionals, patients, and the public, and much more. So if you haven't already visited the MCC website, we encourage you to do so for much more information and resources. And as a note, we're going to be highlighting quite a few tools and resources during this session today. This is by no means an exhaustive list, but just ones that we have found to be helpful and that are also available to you. On those slides where we're going to be highlighting those resources, we've included links and information at the bottom of the slides for you to be able to locate and revisit those if you'd like as well. So we have 5 objectives for this session today. During this presentation, we will be explaining local prevalence of commercial tobacco use, lung cancer incidence and mortality, and also why it's so important for detecting lung cancer early through screening. We'll be describing current recommendations for lung cancer screening, eligibility criteria, benefits and risks, and also costs associated with screening. We hope that during our time today, you'll be able to recognize how to identify patients that are eligible for lung cancer screening, conduct a counseling and shared decision-making visit, and also complete the required documentation and coding. We also hope that you'll be able to identify relevant quality measures that will be impacted by those referral processes to lung cancer screening. And then hopefully you'll also be able to identify interventions and available resources to promote awareness of the benefits of tobacco dependence treatment and appropriate lung cancer screening. So to dive in, why should we talk with patients about lung cancer screening? Why should we be making this a priority? There's data that shows awareness of lung cancer screening is actually very low, like this Lung Health Barometer survey from the American Lung Association's Lung Force Initiative. This was a survey that asked over 1,000 women and men in the United States about their understanding of lung cancer and screening. And what they found was that among high-risk current and former smokers, only 15% were aware that screening for lung cancer is recommended and also covered by Medicare and most healthcare plans at no cost to them. It was also found that 84% of the high-risk population was unfamiliar with the only recommended lung cancer screening test available, which is the low-dose CT scan, and we'll be talking quite a bit more about that today. The survey also found that 41% of high-risk current and former smokers did not plan on getting screened for lung cancer, and that the top reason that those at risk gave for not getting screened was that their doctor had never recommended it. Similarly, there was a morbidity and mortality weekly report that came out earlier this year from the CDC on the importance of lung cancer screening to save lives. So we know that lung cancer is the #1 cause of cancer deaths, and also that screening with low-dose CT can detect lung cancer early and save lives when treatment can be more effective. But like we saw with the Lung Health Barometer results on the previous slide, this report also concludes that more screening is needed. So the report was based on behavioral risk factor surveillance system data from about 10 states that had administered new questions on lung cancer screening. And they found that 7 of 8 adults who met the screening criteria did not report receiving recommended screening. As a result, the report calls for more patient education, especially from primary care providers and care teams as those trusted individuals that patients are engaging with regularly. And so a key takeaway from both of these reports is that there's this great opportunity for healthcare providers, and especially those in primary care, to impact community awareness of lung cancer screening and play a very important role in reducing lung cancer mortality by having this conversation with patients who are at risk. So knowing that there's this need on a national scale to talk more with patients about lung cancer screening, we now want to get more into the burden of tobacco use and lung cancer among our statewide communities. Here we have smoking rates by region, with lower rates starting at 11.8 in light yellow, and then darkening as rates increase up to 32.8. We know that tobacco is one of the strongest cancer-causing agents, and that smoking is the leading cause of lung cancer. There's also evidence showing that risk of lung cancer from smoking cigarettes increases with number smoked per day and number of years smoked. And in looking at this map, hopefully you're able to pinpoint your county or where your organization is located to see where the population that you serve is falling within this range of smoking burden. Highest burden areas are colored in dark burgundy. So we see quite a bit in the mid to northern lower peninsula, in the eastern lower peninsula over by the thumb, and then across the UP as well. And this can give us an idea of what proportion of the people in our communities are impacted by this leading risk factor of smoking. Taking this risk factor of commercial tobacco use from a general population snapshot like we just saw, and then looking at trends in use, we can see that the proportion of adults reporting using cigarettes has decreased. So from 23.3% in 2011 down to 19.2% in 2017. When we look at adult smokeless tobacco use, again, we see a decrease from 4.4% in 2011 to 4% in 2017. For adults using e-cigarettes is this topic that's been gaining a lot of attention within recent years. And so the first available data point we have for this is about 4.7% of adults reporting using e-cigarettes in 2017. And then also for the same year, 2017, looking at youth tobacco use, we see that 10.7% of youth report using cigarettes, 6.3% report using smokeless tobacco products, and that 14.8% report using e-cigarettes. And so I think it's important to kind of bear in mind what that burden looks like in the youth population as well, as early intervention and hopefully tobacco cessation counseling will help these patients to maintain, a healthier lifestyle and hopefully avoid risk for lung cancer later on in life. The downward trends that we're seeing in adult cigarette and smokeless tobacco use are encouraging, though when the data is broken down by demographic factors, like we see in the chart below, we can see that some populations are experiencing higher burden. So the Native American population has the highest burden of cigarette use, 42.6%, indicated in that green bar, as well as smokeless tobacco in navy blue and e-cigarettes represented in orange, compared to individuals of other races and ethnicities in Michigan. Individuals identifying as bisexual or gay report higher cigarette use, so 39.1% and 29.9% respectively, compared to individuals identifying as straight. And we see the same trend again for e-cigarette use in these groups as well. And then looking geographically, we see slightly higher cigarette and smokeless tobacco use in rural populations compared to urban, while urban populations have higher burden of e-cigarette use. Moving from tobacco use as a risk factor to lung cancer incidence and mortality throughout the state. So the map on the left shows lung cancer incidence with lower rates starting at about 17.2 in light yellow, and then darkening as rates increase up to 118.9 per 100,000. The overall state lung cancer incidence rate is 60.54 per 100,000. Here we see quite a few counties exceeding the state rate, with areas of highest burden noted in red in the northern central region of the lower peninsula and also in counties in the eastern upper peninsula. The map on the right is showing lung cancer mortality rates, with lower rates ranging from 0 to 38.52 in light yellow, and then again darkening with increasing rates up to 92.19 per 100,000. The statewide lung cancer mortality rate is 42.22 per 100,000. And again, we see a number of counties experiencing the highest rates in the northern lower peninsula, concentrating in the northeast, as well as in counties across the Upper Peninsula. So again, hopefully you're able to sort of visualize where your county is as far as incidence and mortality. Those areas with higher incidence indicate cases are being detected, though if we're also seeing high mortality rates in those areas, it may be that cases are being detected at later stages, which we'll also talk more about in just a bit. We just saw that recent snapshot of incidence and mortality. So now looking at trends over time. Here we have Michigan lung cancer incidence and mortality compared to the US over a span of 18 years, so from 1999 to 2016. In this chart, Michigan is displayed in blue for both measures. So up top in light blue is incidence, about 75 in 1999 and decreasing to 60.5 per 100,000 in 2016. So here we're seeing a decrease in incidence of about 20%. The state incidence rate exceeds the US rate throughout this entire time period. Below that is mortality. So Michigan is represented in dark blue, about 56 in 1999 and decreasing to 43.7 per 100,000 in 2016. So here we see a decrease in mortality of 22%. State mortality rates again exceed US rates throughout this time period, with the gap also widening over time. Again, it's encouraging to see these downward trends. Though breaking things out again, here we have new cases and deaths by race and ethnicity. We're still seeing disparities. US and Michigan rates are on the far left in each category, the striped column and the darkest blue column respectively. So on the left for new cases, what we can see is that Native American males and females have the highest incidence rates, followed by Black males and white males. And then when we look at deaths, again, we see Native American males with the highest mortality rate, followed by Black males and white males. So while over time we've made strides in reducing overall lung cancer incidence and mortality, there are still groups being disproportionately impacted by lung cancer, which is why patient education and promoting community awareness for lung cancer screening is so important. Building on what we are seeing as far as incidence and mortality, data shows that survival is largely impacted by stage of diagnosis. So starting with the pie chart on the left, the large green portion indicates that almost half of lung cancers are being detected at distant stages, so 48.3%. And at these stages, this involves lymph nodes and other organs, and this is when the cancer is more difficult to treat. 22% of cases are being detected at regional stages, where there can be extension beyond the limits of the organ. And 20.8% are diagnosed at localized stages, where there's no spread beyond the organ. So currently, most lung cancers are being detected at that distant stage. This is important because when we look at the chart on the right, we see consistently lower 5-year survival rates for diagnoses at the distant stage, so our biggest piece of that pie chart from the left. Survival rates increase when diagnosed at a regional stage and are the highest in localized stages among each group that's highlighted here, so Black females and males and white females and males. So the key takeaway here is that early detection is key for increasing survival, which speaks to the need for timely identification of patients at high risk and timely referral to screening. We want to say a quick thank you to the Michigan Department of Health and Human Services for making this data available, and I think it really helps to frame the important risk factors and burden of lung cancer statewide, and also call attention to some areas for potential intervention. So hopefully throughout those previous slides, you were able to note where your county or region was on those statewide maps, and also maybe think about your patient populations when looking at the data broken down by demographics. Getting a little bit more specific, through our Cancer Control Initiative, MPRO is able to work with clinics individually at no cost to support tobacco cessation counseling processes and also referral of eligible patients to lung cancer screening. One of the resources that we provide for this is a lung cancer screening practice snapshot, which we've included an example template of here. The purpose of this tool is to collect information in one place that speaks to how your patient population is impacted by risk factors and the current burden, and also hopefully to highlight areas for action to improve tobacco cessation counseling and referral to lung cancer screening. This tool is customizable, so the clinic's name would appear at the top, and then the county of the organization or the clinic would be in the middle, and kind of pulling smoking prevalence and lung cancer incidence from both the left and the right in those maps. There's also space for practice-specific metrics for tobacco cessation counseling, lung cancer screening referrals, and the patient population demographics as well. So you see those demographics popping up in the bottom left and the upper right corners. And then also in the middle on the bottom, we have a space for information for the facility that's being referred to for lung cancer screening. So if a clinic is already referring patients to lung cancer screening facilities, we can include that information there. If you're just starting out this process and looking for where to refer patients, MPRO can help out with that as well. And then we can make that contact information available on this tool so that the whole care team is able to find that pretty easily. If you are interested in this resource, Elise and I will both have our contact information listed at the end of the slides today. So feel free to reach out to us, and we would be happy to help you work on this. Now we'll get a little bit more into information on low-dose CT for lung cancer screening. So specifically, screening test effectiveness and also reimbursement and coverage. So first, what is a low-dose CT lung cancer screening? This is a non-contrast CT scan performed on patients who are at risk for developing lung cancer. And so you may have also heard it referred to as low-dose CT, helical CT, spiral CT, and for our purposes during this session today, we'll be referring to this screening test as LDCT. LDCT uses X-rays to get multiple image scans of the entire chest, and this is done within about 7 to 15 seconds. While standard chest X-ray produces a single image of the whole chest where anatomic structures overlie one another. What we know about LDCT versus chest X-ray for lung cancer screening largely comes from the National Lung Screening Trial, or NLST. This study was needed as lung cancer is the leading cause of cancer-related death in the US, and most lung cancers are detected when they cause symptoms. By this time, the disease has often already spread outside of the lungs, so researchers were looking to develop methods to screen for lung cancer before symptoms became evident. So this study compared two ways of detecting lung cancer, LDCT versus standard chest X-ray. This study enrolled over 50,000 former or current heavy smokers, and so that was defined as 30 pack years. So for example, 1 pack smoked per day for 30 years, 2 packs a day for 15 years, and we'll get more into that later in the presentation as well. And then the study population was also ages 55 to 74. So within the study, participants were randomly assigned to 3 annual screenings with either LDCT or chest X-ray. And what they found was that participants who received LDCT scans had a 15 to 20% lower risk of dying from lung cancer than participants who received standard chest X-rays. So that 15 to 20% translates to about 3 fewer deaths per 100,000 people screened with LDCT compared to chest X-ray over an average of 6.5 years of follow-up. This study also found that adenocarcinomas and squamous cell carcinomas were detected more frequently at the earliest stage by LDCT compared to chest X-ray. And so again, from those previous slides and the data that we saw, we know that early detection is key. As a result of NLST evidence, lung cancer screening with LDCT is designated as a grade B recommendation by the U.S. Preventive Services Task Force, or USPSTF. This means that the service is recommended, as there's moderate certainty that the benefit of the service is moderate to substantial. So this grade B recommendation also means that coverage is required with no cost sharing in many private or employer-sponsored health insurance plans, and by Medicaid in states that have accepted Medicaid expansion. And we'll also talk more about coverage today. So you can see that the population and the actual recommendation listed here align really closely with that study population from the NLST. So for the general population, the recommendation is looking at adults aged 55 to 80 with a history of smoking. And that recommendation is for annual screening for lung cancer with LDCT in adults aged 55 to 80 years who have a 30 pack year smoking history and either currently smoke or who have quit within the last 15 years. And just to point out too, for eligible patients, the recommendation is for screening once a year. So rather than just a one and done scan, we want to make sure that patients understand that due to their risk, lung cancer screening is something that they will do each year with the purpose of detecting changes over time. It's also recommended that screening should be discontinued once a person has not smoked for 15 years, or if they develop a health problem that substantially limits the life expectancy or their ability or willingness to have curative lung surgery. So according to Behavioral Risk Factor Survey data, the overall lung cancer screening rate in Michigan is 6.4%. So this is the percent of people meeting these criteria that have been screened in the last year. So at only 6.4%, we know there's certainly room for improvement in identifying and getting these patients referred for lung cancer screening. Another topic that comes up related to lung cancer screening with LDCT is radiation exposure during the scan. So screening for lung cancer exposes a person to a low dose of radiation, though this type of scan uses less radiation than a regular CT scan. If the screening test is positive, additional testing may involve higher doses of radiation. I think this chart is really helpful for comparing the amount of radiation exposure from an LDCT scan compared to other sources of radiation, and also could be helpful for patient education as well. So here it lays out different sources measured in millisieverts, or the amount of radiation absorbed by the body. Highlighted here, we see that one LDCT scan for lung cancer screening comes in at about 1.4 millisieverts. This level may vary based on patient size. Toward the lower end of the spectrum, we can see that air travel for about 10 hours is coming in at 0.04. Where a chest x-ray is coming in at 0.1 millisieverts, a mammogram comes in at 0.4. We have our LDCT for lung cancer screening at 1.4. And then on the higher end of this particular spectrum, they also lay out average background radiation within the United States over 1 year. That can range from 3 to 5 millisieverts. And then on the highest end of this spectrum, we have a diagnostic CT, which is about 7. At this time, researchers don't know how exposure to radiation from LDCT scans and additional diagnostic imaging may affect people, though based on the available evidence, the benefit of potentially finding a treatable cancer appear to outweigh the radiation exposure risks of the procedure. So as LDCT is a grade B recommendation from the USPSTF, Medicare and many other payers cover this as a preventive service at no cost for individuals meeting the eligibility criteria. If a patient does want to complete lung cancer screening, but doesn't meet the eligibility criteria, maybe they have a different risk profile outside of the recommendation, but the patient and the primary care provider discuss and feel that it may be beneficial. If they are outside the current eligibility criteria, there will likely be a cost to them to have that LDCT scan. So just as an example, one screening program's cost was about $244 plus a radiologist reading fee. There is a lot of variation in cost depending on the screening facility. So again, this is just one example. We recommend getting in touch with your local screening facility if you're looking for more specifics on pricing. And if you're looking for some assistance to do that, feel free to reach out to MPRO and we would be happy to help out with that as well. More on the end of facilities actually offering screening services, lung cancer screening is associated with CPT code G0297 and 71250 if the patient needs to come back for a follow-up exam. So now getting more into coverage. The American Lung Association has a couple of great resources, which we've linked at the bottom of this slide, on coverage for lung cancer screening. And so what we did was pull this information together into a summary table of known coverage details by health plan. We do want to note that coverage will depend on patients meeting screening eligibility criteria and also being referred through the proper process, and also possibly by other payer-specific criteria. But just to summarize, across the top, you'll see different payers. So we have here employer-sponsored plans, Medicare, state health insurance marketplace plans, individual plans, and also Michigan Medicaid. And then along the left side are coverage details. So within that first row, we just made note of any differences from the USPSTF eligibility criteria that we saw in the previous slides. So most of the deviation that we see comes in for the age group. So again, USPSTF is looking at that age group from 55 to 80 years old. And across the board, most plans are also following this age recommendation, with that difference coming in when we look at Medicare. So under Medicare, we see that the age range that they're identifying as eligible for coverage will be ages 55 to 77. So just a slightly smaller range there. In the next row, we summarize any expected cost sharing. So across the board, the answer is pretty much no, with the note being that there may be a copay if that facility is considered to be out of network for the patient. And then over under Michigan Medicaid, we can see that this service is covered without cost sharing under Medicaid expansion. Moving to the next row and looking at any additional costs that may be anticipated. Again, across these plans, the answer is in general no, with the note just being that there may be facility fees. So the best thing that we can do is just check that that facility where the patient is going for lung cancer screening is considered to be in network for the patient. And then in the last row, we just summarize any other notes. So both for the employer-sponsored plan and the individual plan, there is a note that if the plan is grandfathered in under the ACA, that plan may not be required to provide lung cancer screening coverage. Looking under Medicare, Medicare Advantage plans may cover screening greater than age 70. And then over to the right under Michigan Medicaid, we see that no prior authorization is required and that coverage may vary between fee-for-service and managed care plans. So again, we encourage you to take a look at those resources from the American Lung Association. They're linked at the bottom of the screen, both for your practice and for more information if patients need that about their payer as well. So we've talked about LDCT lung cancer screening and the recommendation for eligible high-risk patients to be screened annually. So what happens if the screening test is positive? In this case, additional testing may be needed, like a lung biopsy or surgery to obtain specimens. Studies have found that 20 to 60% of screening CT scans of current and former smokers will show abnormalities, though most of these abnormalities are not lung cancer, so they're false positives. And those could be things like scars from smoking, maybe areas of inflammation, nodules, and other abnormalities. These couple of pieces are also important to talk about with patients and address during counseling and shared decision-making visits for those who are considering completing lung cancer screening. And now I'm going to go ahead and hand it over to Elise, who's going to talk more about identifying eligible patients.
Thanks, Julie. So today I will be covering how to identify your eligible patients using the U.S. Preventative Services Task Force criteria, as well as how to use your EHR to identify these eligible patients, as well as how to document that within your EHR. So to begin, for a patient to qualify for low-dose CT lung cancer screening, they must meet the following criteria. The person must be 55 to 80 years of age, while Medicare coverage criteria includes those 55 to 77, as Julie had mentioned earlier. They must be showing no signs or symptoms of lung cancer. They have to have a tobacco smoking history of at least 30 pack years. So 1 pack year equals 1 pack per day for 1 year. 30 pack years would be 1 pack per day for 30 years, 2 packs per day for 15 years, and so on. And 1 pack equals 20 cigarettes, as some pack year calculators ask in the number of cigarettes and not the number of packs. So that is important to know. And then lastly, the person must be a current smoker or have quit within the last 15 years. So there are different ways that you can calculate pack years. If this is something that is fairly new to you, we would definitely recommend using a pack year calculator or using your EHR to document pack years. ShouldIscreen.com is the screenshot you see here, where you are able to plug in for how many years the person has smoked and on average how many cigarettes they smoked a day. So that's where that number of cigarettes comes in here. And then it will auto-calculate the pack years for you. SmokingPackYears.com is another online resource that you can use, and it also allows you to enter different forms of tobacco use, such as cigarettes, cigars or spliffs, cigarillos, pipe, water pipe, and so on. So that's another helpful resource, especially if you have patients who are not just smoking cigarettes. Some EHRs will also calculate pack years for you as you document their smoking history within the EHR. So this is a screenshot that you can see from Epic, that as you're documenting the person's smoking status, their start and quit date if applicable, the type of tobacco product, their packs per day, and their number of years, the EHR will auto-calculate pack years for you. So if your EHR already has this built into it as you are documenting the patient's smoking history, this is a very useful tool. If that's not something your EHR is doing, then again, we would recommend using some type of pack year calculator, as that number is really important during the referral process for your patients. By identifying your eligible patients for lung cancer screening, your quality measures can also be impacted in a positive way. The more you're identifying your current tobacco users and providing tobacco cessation counseling and documenting that within your EHR, you'll be able to see these quality measures move. The first quality measure being the HEDIS measure, medical assistance with smoking and tobacco cessation, where you're identifying those current smokers or tobacco users, advising them to quit, discussing cessation medications, and discussing cessation strategies. The second measure being CMS measure, preventative care and screening for tobacco use, screening and cessation intervention, where you are identifying those and screening patients for tobacco use within the reporting period. And then that person, if they are identified as a tobacco user, is receiving tobacco cessation intervention. For tribal health clinics, there are also tobacco cessation JIPRA measures that can be affected when identifying your eligible patients. The first measure being the tobacco use and exposure assessment, where patients are being screened for tobacco use during the reporting period. They're identified during that reporting period as a current tobacco user, or they're also identified as being exposed to environmental tobacco smoke during the reporting period. The second measure being tobacco cessation measure for those patients who receive tobacco cessation counseling, received a prescription for tobacco cessation aid, or quit their tobacco use anytime during the reporting period. Once you identify your eligible patients for lung cancer screening, there are some important steps to take during the referral process to ensure the patient receives screening services and that you are reimbursed for the patient care you provided. The big piece during this referral process is the counseling and shared decision-making visit. So before the first low-dose CT screening can occur for your patient, the patient must receive a written order for lung cancer screening during a lung cancer screening counseling and shared decision-making visit. And this must be conducted by a physician or a qualified non-physician practitioner, for example, a PA or an NP or a clinical nurse specialist. The shared decision-making visit must include all of the following. They must use one or more decision aids with the patient. They must discuss the benefits and harms of screening. So as Julie had mentioned, talking about radiation exposure and if that is a concern with your patient. They must also talk to the patient about what follow-up diagnostic testing looks like should they receive a positive screen. And then lastly, they must talk about the chances of overdiagnosis and treatment, again, as Julie had mentioned, with those false positive rates. If applicable, the person must also receive counseling on the importance of beginning tobacco smoking abstinence, or also reinforcing the person to maintain their tobacco smoking abstinence if that is the case. They also must provide information about tobacco cessation interventions, if applicable, to this person. And then at the end of the counseling and shared decision-making visit, once the physician or qualified non-physician practitioner goes through all of these pieces with the patient, and they both agree that the patient is willing to go through lung cancer screening, that is when that written order would be given to the patient for low-dose CT. An important note too, for subsequent annual lung cancer screenings, the patient must continue to receive a written order for low-dose CT screening, but this can be given to them during any appropriate visit with their physician or qualified non-physician practitioner. So these are some examples of resources that you can use when talking with your patients about eligibility criteria. The resource on the left is a resource developed by Enpro that guides the patient through the eligibility criteria in very easy to understand examples. And the orange responses will eventually guide them to talk to their doctor about lung cancer screening should they meet all of that eligibility criteria. If they do not, it does lead them to other calls to action, such as contacting the Michigan Tobacco Quit Line if they do identify as a current smoker. ShouldIscreen.com is a University of Michigan website that I had mentioned with that Pack Your Calculator. It also has eligibility criteria questions built within it that you can have patients click through, where it prompts them questions related to eligibility and also has very great information about lung cancer screening for them. So circling back to the counseling and shared decision-making visit, this code to bill for the counseling and shared decision-making visit is G0296. The definition being a counseling visit to discuss the need for lung cancer screening using low-dose CT scan. And the service is for eligibility determination and the shared decision-making piece. So this code is very important when going through that visit with the patient. Counseling and shared decision-making visit code, again, G0296, must be billed with the ICD-10 diagnosis code Z87.891 to show the personal history of tobacco use. This is a very important piece of the referral process, that these two codes are billed together, and that will ensure that the patient receives the screening service without any unexpected out-of-pocket costs, and will also ensure that you are reimbursed appropriately for that shared decision-making visit. Once the patient and provider complete that shared decision-making visit and agree to lung cancer screening, the written order for lung cancer screening would then be given to the patient. The accredited lung cancer screening facility that you are referring the patient for lung cancer screening may have their own form to fill out, but most of them require the following elements: the patient's date of birth, the calculated Pack Your smoking history in a number, so again, we're looking for 30 or higher, their current smoking status, and for former smokers, the number of years since quitting, a statement that the patient is asymptomatic, otherwise showing no signs or symptoms of lung cancer, and lastly, the NPI of the ordering practitioner. Some forms may also ask you to indicate the type of exam, whether it's an initial screening or a subsequent exam. The American College of Radiology, or ACR, has a list of ACR accredited facilities. Those accredited facilities have the Lung Cancer Screening Center badge, which indicates a facility is an ACR designated lung cancer screening center. And that means they have at least one accredited CT unit that meets the minimum requirements for acceptable lung cancer screening performance. You are able to search accredited facilities in your area using this link here, and you can actually search distance from where you are located. So you can search 25 miles away, 50 miles away, and it will give you a list of those ACR accredited facilities in your area, which you are also able to download. I did this search for the entire state of Michigan just to give you a visual of ACR accredited facilities in the state. So now we're going to talk about interventions to promote lung cancer screening. We'll talk about client reminders, provider reminders, one-on-one patient education, and small media. These are all evidence-based interventions that you can implement in your practice to help promote lung cancer screening in your practice. So client reminders are strategies to remind your patients that they are due or overdue for screening outside of the clinical setting. So this is typically a reminder that they are receiving at home. Reminder messaging can be in the form of letters, postcards, phone calls, patient portal messaging. The opportunities are really endless for how you can remind your patients that they are due or overdue for lung cancer screening. Reminders can also be very effective when the messaging is tailored to your patient population. So if you have a patient population that primarily speaks Spanish, providing reminders in your patient's preferred language is going to be much more effective. The American Cancer Society has helpful and straightforward resources that you can include in your reminders, and they also have Spanish options as well. If you would like assistance finding resources in other languages, please reach out to us and we can help connect you to those. Provider reminders are prompts for your providers that a patient is due or overdue for screening during their visit while you have the patient in the office. Julie had mentioned earlier how important these reminders are because there is so much to cover with your patients while you see them, so a reminder is very helpful. Provider reminders can be in the form of clinical decision support alerts in your EHR, where perhaps a flag or a ribbon pops up on the patient chart, or maybe something turns red. So it would be very helpful to implement provider reminders for lung cancer screening within your EHR if that is possible. If not, provider reminders can take on the form of other types of physical cues, such as a colored sticky note on a door of an exam room, or even attaching this resource on the right to the top of other items that are being brought into the visit with the patient. And this resource on the right would really prompt and speak to the provider that, hey, we think this patient is eligible for screening, they fall within this age range, we know that they're a current or a former smoker. So this is a really helpful resource where it has the checklist to determine the patient eligibility for screening, and then it also has steps for the counseling and shared decision-making visit, and then what the written order has to include as well. So this is another way that you can prompt your providers in the office to check a patient eligibility criteria and then move forward with lung cancer screening if appropriate. Patient education and small media are also ways that you can help inform your patients of what lung cancer screening is, why it's important, and what makes them eligible. So on the bottom right, you see the shouldiScreen.com website. This is, again, another great resource that you can refer patients to click through to determine their eligibility, to look at more information about lung cancer screening and what that is. The lung cancer screening myths and facts sheet on the left was developed by MPRO in partnership with Hills and Dales General Hospital, as they noticed a gap in knowledge with their patients around lung cancer screening. There were a lot of misconceptions around lung cancer screening, and they felt like they were answering the same questions over and over again, but that there was no education that you could hand to a patient and go through with them and have them take that education home. So we developed this resource with them to really combat those misconceptions and already have this information out there for patients to look through. The last strategy to promote lung cancer screening we wanted to discuss is establishing a physician champion. As we've worked with clinics on their lung cancer screening referral processes, we saw how important it was to have someone championing the program to drive screening forward in their clinics. Some common best practices we found that the champion provided, first of all, being talking with their fellow physicians about the importance of referring patients to lung cancer screening and what that referral process looks like. We've also had physicians talk to their peers about the difference between low-dose CT scan for lung cancer screening compared to a chest x-ray, as that has been an updated recommendation in the past for low-dose CT, and they found that some providers were still referring patients for a chest x-ray instead for lung cancer screening. So that was a really important piece too, to have the physician champion educating their peers around current lung cancer screening recommendations. They've also formed steering committees to talk about their progress and problem solve any issues. This is where they really review their data around lung cancer screening referrals and where they are now compared to where they are last year and where they wish to be. This is also where they're identifying any blips or any barriers to referring patients. This is where they're educating one another about any updated recommendations for referrals, or if they're seeing that perhaps patients are being returned back to their practice because there was some issue in the referral process. So this is where they really were ironing out those details within the steering committee. Also within that committee, they're able to identify those patient barriers and have those conversations around the barriers and what education that they can provide to patients for patient barriers, as well as any strategies to help combat those barriers. This is actually where the myths and facts sheet came to be, was in the steering committee talking about that. So whether you are in the beginning of lung cancer screening referrals in your practice, or perhaps you've been doing this for a very long time, do you have a physician champion? If you don't, who would that be? Where do you see this physician champion fitting in your practice and what their roles would be when it comes to lung cancer screening for your patients? So now we're going to talk about resources for tobacco dependence treatment and lung cancer to provide to your patients. If you're a part of a health system, there may be local tobacco dependence treatment programs available to your patients in the form of classes or one-on-one education or coaching over the phone. There are some community programs that exist that you can search in your area. There's also American Lung Association's Freedom from Smoking Group Quit program, which offers many options to people looking to be part of the program. They have an online option, which includes phone and chat support. They also offer in-person clinics where you can look online on this link here or call their number for locations and days and times for these in-person clinics. They also have a lung helpline and a self-help guide for those hoping to do this on their own. Lastly is the Michigan Tobacco Quit Line, which is a very popular program in Michigan that we'll talk about in just a minute. If you'd like assistance locating a local program to refer your patients to, please reach out to us and we can help connect you to what's available in your area. So if you're not familiar with any local tobacco dependence programs, you can also refer patients to the Michigan Tobacco Quit Line. This is a very great program and has seen a lot of success. The Quit Line offers personalized coaching available 24/7. This can happen over the phone, email, and texting, where they help the person make a quit plan and set a quit date. They help them identify their tobacco triggers and how to manage their cravings, and also help with strategies to get back on track after relapses. The Quit Line also offers nicotine replacement therapy and offers 4 weeks of free nicotine replacement therapy for qualifying patients. What's also really great about the Quit Line is having membership in an online community, because it really is difficult to do this on your own. So that online community is a really important piece too. So many people can qualify for counseling through the Quit Line. Medicare and Medicaid patients, patients with county health plans, uninsured patients, veterans, patients with a cancer diagnosis, pregnant women, and youth. There are different ways that you can refer patients to the Quitline. There is the provider web referral, where you're able to enter the clinic and patient contact information as well as their preferences. There's the option for e-referral, where you're able to refer patients through your EHR, although you must be set up with the Quitline first in order to utilize e-referral. And lastly, and probably the most popular one, is a fax referral form, which you see here on this slide. And there's sections to complete for both providers and for patients. And the fax number to fax it to is at the bottom of the form. So it's a really easy form to fill out and send to the Quitline. The American Cancer Society is a great hub for tobacco cessation and lung cancer resources. This slide includes some of those tobacco cessation resources that you can provide to your patients when having these conversations. What's really nice about American Cancer Society resources is the option to co-brand. You can see at the bottom right-hand corner of the middle handout that there is an option to upload the PDF logo of your clinic. The American Cancer Society is a very well-known brand, but patients are going to trust information coming from a familiar source, such as their doctor's office that they're visiting frequently. So providing trusted resources from the ACS with your logo attached, patients are going to be very willing to be more receptive to that information. The American Cancer Society also has videos that you can have patients look through. A really important one that I feel is that lung cancer screening with a low-dose CT scan video. I know I'm a very visual person and I like to see what I'm getting into before I agree to anything. So this is a nice video that you can show patients so that they know what to expect, or if they're kind of on the fence about lung cancer screening, they can see, how quick and painless it is. There's also some smoking cessation videos that you can refer patients to look at as well. The last resource we want to share with you is the provider version of the Decision Aid tool. So on the right-hand side, you've seen this patient version already. There's also a provider version, which includes a little more detail around that eligibility criteria. It goes the same way with the orange responses, eventually leading to lung cancer screening. And that lung cancer screening final orange box also includes those codes and the reminder to conduct a counseling and shared decision-making visit with the patient. It also has the provider refer the patient to the Michigan Tobacco Quitline if applicable. And what's really great about both of these resources is that they can be personalized. So if you have a local program that you're referring patients to, that can be also plugged into this resource. So if that's something you're interested in doing, again, please contact us and we can work with you to do that. So as a reminder, to earn CME credit or a certificate of participation, you need to read the introductory CE information, view the webinar, complete an evaluation using the provided link, and then this learning activity will be available for credits for 1 year. You can access and complete the post-evaluation survey at this link here. And again, if you have any questions, my contact information and Julie's contact information is on this slide. And thank you so much for joining us today.